Hello and welcome to lectures on cardiac morphology and congenital heart disease. In this video, we will review the sectional anatomy and sequential segmental analysis. We will look at short axis sections and we will look at four chamber views. We will look at peristernal long axis views. We will look at the heart and the whole body specimens. We will look at bronchial pattern, liver, pre-duodenal portal vein, and finally we will look at complete transposition of the great arteries, normal and corrected transposition of the great arteries. Let's look at these specimens. First is a short axis of a heart sample, human heart sample, cut in a short axis. This is the left ventricle, this is the right ventricle. We can see here the septum and the two papillary muscles, the anterolateral and the posteromedial papillary muscles. Here we can see a good correlation of this cut to the echo correlation. We can see the hypertrophy of the septum, as you can see. The difference between here and the echo is that in echo we see the cardiac mass moving forward and backward. So we'll see more segments. We can cut down and up along the axis of the heart. But it is very important to correlate and to know the morphology on specimens to be able to correlate that to the actual echo views. Let's compare this specimen to this other specimen on the left. Same cross section. However, notice the difference in the amount and the type of hypertrophy that is on the left. As you can see, the heart on the left shows significant left ventricular hypertrophy with a much smaller left ventricular cavity. And the right ventricle is also hypertrophied as well. However, the right ventricle is slightly dilated. So the fact that the cavity of a chamber is maintained does not rule out hypertrophy. The weight of the myocardium or the myocardial mass that determines hypertrophy. On the right here, we can see the hypertrophy is concentric and on the left is eccentric, which has different physiologic implications. Now, let's look at other specimens. So let's put these short axes together to have a whole view of the whole cardiac mass. And let's determine what are the cardiac axes, the long and the short. The long axis of the heart starts from this point in the cardiac apex, and a connection between that and to the aortic valve is what gives us the long axis of the heart. Perpendicular to that is the short axis. So as you can see, we can have several short axes starting parallel to the AV junction. If we look at the first one here, we can recognize the mitral valve. This is the anterior leaflet of the mitral valve, which is also the inflow of the mitral valve, and the posterior leaflet of the mitral valve. And here's the posterior medial papillary muscle and the anterolateral papillary muscle. This is the midline, so that's the medium. That's why this is the posterior medial and this is the anterolateral. If we look at the right ventricle, we can see here the infundibulum, and here we can see the tricuspid valve. This is the septal leaflet of the tricuspid valve. And we can see how it's attached to the septum, opposed to the mitral valve leaflet, which is different. The mitral valve leaflet is not attached or does not have attachment to the septum, only through the papillary muscles. If we look here, we can see that the anterior leaflet of the mitral valve is in fibrous continuity with the aortic valve, and we will look at that later. Here we see the anterior superior leaflet of the tricuspid valve and the inferior posterior leaflet of the tricuspid valve. This is the diaphragm here, so that's why this is not only the anterior but also superior leaflet, and this is not only the posterior but also the inferior leaflet of the tricuspid valve. Compare this to the mitral valve, which has a continuity, fibrous continuity between the anterior leaflet and the aortic valve that we see here if we look through. And so the anterior leaflets separate the inflow of the mitral valve to the outflow to the aortic valve. Compare that to the pulmonary valve here, which is separated from the tricuspid valve by this thick muscle bundle that is called the crista supraventricularis. Let's take a look at the second short axis. We can see here the posterior medial papillary muscle and the anterolateral papillary muscle. Here we can see the anterior papillary muscle and the posterior papillary muscle in the right ventricle. Another easy section that and very nice is a section that is parallel to the diaphragm. If we cut the heart in a plane that is parallel to the diaphragmatic sulcus, cutting from the right atrium, this is the right atrium, this is the right ventricle, and we cut in parallel to the diaphragm, we can get a good view of the inflow of the heart. If we place the transducer, what we do in echo, we place the transducer right here at the apex, and we get what we see here as the four-chamber view. In this four-chamber view, we can see the right atrium, the right ventricle, the left ventricle, and the left atrium. This is also part of the left atrium. Now, if we move the transducer anteriorly, we can see this is the beginning of the aorta. And if we move the transducer more anterior, we can see the continuity or open up the aorta. So you can see the inflow of the left and the inflow of the right are parallel to the diaphragm. However, the outflow of the left ventricle is angled more superiorly and crossing with the RV outflow tract. In the right atrium, we can see the crista terminalis, which is the thick muscle bundle that separate the sinus venera to the pectinated muscle or the free wall of the right atrial appendage. And further down, we can see here the wall that separates the atria to the vestibule, which is where the separation occurs right above the tricuspid valve. And right next to it is here the fat tissue. This fat tissue separates the right atrium from the right ventricle and creates an insulation for the conduction system. And it's on this fat tissue right at the insertion of the tricuspid valve where the fibrous tissue as well starts. And this is also where the right coronary artery courses. This is where the location of the right coronary artery. Now, this is the interventricular septum. And if we look here, this part of the septum separates the left ventricle right underneath the aorta to the right atrium. So this part of the septum separates the right atrium and the left ventricle. So it's called the membranous atrioventricular septum. If we move more anterior, you can see that this tricuspid valve leaflet will also take an anterior course, and another part of the septum right here will be in between the left ventricle and the right ventricle, and it is also in this section that we can look at the left atrial morphology. You can see here the left atrium. This is the pulmonary vein, and here's the inflow, the mitral valve. If we put the heart together this way and look at it from the side, we can see here the anterior tip of the atrial appendage, right atrial appendage, and this is the left atrial appendage, and we can see the crest that separate the left atrial appendage, or the ridge that separate the left atrial appendage from the upper pulmonary vein. This is separated by this thick muscle bundle right there, or this crest or ridge. Another way of cutting the heart, let's look at this one here. So here's the sternum. So if we want to do a long axis parasternal view, correlating with what we do on echo, this would be the parasternal long axis view, cutting from the aortic valve to the apex, but from in front of the sternum. However, the pulmonary trunk will be right in front of us, coursing this way. So in order to do that cut, we have to cut through that right ventricular outflow tract, right there. So let's look at that section. So this is the parasternal long axis section. This is the right ventricular outflow tract that we cut through. This is the interventricular septum. This is the anterior part of the septum. This is the posterior left ventricular septum. This is the aorta and the ascending aorta. And this is the non-coronary cusp. And right there is the anterior leaflet of the mitral valve in continuity with the aortic valve. This is the left atrium, the anterior wall of the left atrium, separated from the aorta by the transverse sinus. This is the inferior wall of the left atrium, as you can see. And here we can see a big vascular structure. This is the coronary sinus that drains the cardiac venous blood to the right atrium, right there in the back. Here's the right atrium. And then here you can see also fat tissue separating the left atrium and the left ventricle. It is in this fat tissue that the circumflex coronary artery courses. Again, if we put the heart together and look at the external surface, we can see the coronary artery. So this is the left anterior descending, and this is the circumflex coronary artery. Okay, now let's look at specimens showing the heart and the chest. Now the heart fills the chest, but also there are other organs in the chest: the lung, the thymus, the diaphragm, liver, and other abdominal organs. So let's take a look and see what else there to give further explanation of the importance of these other organs and relative to the heart. So, for example, we have here the right lung showing 3 lobes right there, and the left lung, this is the middle lobe, the upper lower, the left lung with 2 lobes. And down here we have the diaphragm consisting of the fibrous tissue that covers the muscular part of the diaphragm, and then the liver with the right large lobe and the left smaller lobe, and the spleen to the left, and the stomach underneath the left lobe of the liver, and the gallbladder right there. And here's the transverse colon and the small intestine. Now, sometimes congenital heart disease can be very simple, VSD or ASD, but sometimes you can have complex congenital heart diseases with other organs involved with these defects. And here comes the concept of laterality that we need to explain. What we call situs is the position or the location of organs. So when we say situs saliens, we mean the usual arrangement. That means right is on the right and left on the left. So as you can see here, the right lung is on the right and the left lung is on the left. And all the other organs are in its place. However, this can be reversed in what is called situs inversus. So it is important to recognize and see what is right and what is left. So again, in this normal heart, let's review that again. We can see that the right lung has 3 lobes. The left has 2 lobes. The right atrium here, as you can see, has distinctive morphology with the appendage, and the left atrium has also a unique, peculiar view of it. The right ventricle is on the right, the pulmonary trunk is anterior to the left, and the left ventricle, the aorta is to the right and posterior, and the left ventricle is to the left. So in some cases, however, this arrangement can be different in that you can have, for example, situs inversus in the atria, so that the left atrium on the right and the right atrium on the left. Or you can have bilateral right atrium shaped, which is called right isomerism. Or you can have bilateral left atrial shape or left isomerism. Okay, as you can see, we have several examples here and several specimens. For example, in this neonatal block, we call this a, oops, let me pick it up here. This is a thoracoabdominal block. We can see that the right lung is on the right, 3 lobes, but also on the left, the lung is also shaped as a right lung. So we have bilateral right lung morphology in this specimen with the middle lobe and the fissures. Now, if we look at the bronchial anatomy, let's turn to the back and look at the bronchus. We can see that both main bronchi are of right bronchi anatomy. And to look at this more details, let's get this other sample that shows it, bigger heart and a bigger bronchus. So we can see that the right bronchus is different from the left bronchus. The right bronchus is short, its distance, the length of it is shorter than the left, and also there's this separation between the upper bronchi and the lower bronchi. And we will talk about that separation. Now, the left bronchus is long, and you don't see that separation that we see on the right. So short, right, long, left. And the left pulmonary artery here courses above the left main bronchi and goes into or between the 2 lobes in the major fissure. Whereas on the right pulmonary artery courses in between the upper and lower bronchus. This is why the upper bronchus is called eparterial and the lower main bronchus is called hip arterial. So this space is where the right pulmonary artery courses in between to go through in the fissure into the right lung. Now, so recognizing these patterns are important in determining right and left pulmonary anatomy. Let's move on to this next thoracoabdominal block. In this neonate, we will see that both right and left lung are of right morphology. However, the liver is quite different. We can see here that the left lobe is much larger than the right lobe. But not only the size of the lobes that are different, if we look in the back, we see that the location of the gallbladder is midline and is different. And also look at the portal vein and the portal vascular structure is also unusual midline. Look at the stomach, although it is on the left normally, however, the duodenum, which is here, courses behind the portal vein, which is abnormal. This is not the normal relationship between the duodenum and the portal vein. Look at this normal structure here to see the normal relationship. We see here that the stomach is on the left, and then the stomach pylorus courses and extends into the duodenum in front of the portal vascular structure and makes a shape of a C, but all that is in front of the portal vein, whereas here, as you can see, the C-shaped duodenum is behind the portal vascular structures. And this is very common in isomerism. Now, if we flip the block to the back and look at the esophagus, we can see also that, let's take a look at the distal esophagus. We see that the esophagus also is different. There's a dilation at the distal esophagus, and that's the hiatal hernia of the stomach. Part of it is going there. We'll also look at the systemic venous return. Look at this inferior vena cava that usually does not go through the diaphragm. It is not going through the diaphragm here. Instead, it is coursing upwards and continuing as the azygous vein returning into the heart through the superior vena cava. That's more common in left isomerism. However, it can also be seen in right isomerism. That's another example here of different liver morphology. As we can see here, the liver is also different. The left lobe is a little larger. However, there's also quite different gallbladder position. And if we look here to the back, we can see a significant hiatal hernia present. This is the stomach extending through the diaphragm in the shape of hiatal hernia. It is easier for the radiologist to recognize this actually on radiology, but it's also very important to recognize and make the correlation between radiographic and anatomical specimens. It is very important to recognize this, and that's why we are showing the specimens. So for example, in this heart, we see that the both lungs are normal of right and left morphology. The atrial arrangement is normal, and the ventricles are normal. The right ventricle is right, and the left ventricle is left. However, the great arteries are abnormal in that the right ventricle, as you can see, is connected to the aorta, and the left ventricle is connected to a pulmonary artery. What is also unusual is the location of the aorta, which is usually posterior to the pulmonary artery. Here it is anterior and to the right. Note how the pulmonary artery is to the left and posterior, and the aorta is to the right and anterior. This is important to recognize also on imaging like echo. And let's take a look and compare to the normal anatomy. As you can see here, the aorta on the right specimen is posterior and to the right. However, on the left, this is the aorta is anterior and to the right. So we call this situs solutus, D-loop ventricles, meaning normal arrangement of the ventricles, and dextro or D-transposition of the great arteries. So this is DTGA heart, with the aorta is anterior and to the right of the pulmonary artery coming out from the right ventricle. Okay, let's take a look at this last specimen. Here we can see that the right atrium is connected to a right-sided ventricle that is left ventricle in morphology. So we can, if we look closer, we can see and recognize the left ventricular morphology here, smooth trabeculations, bullet-shaped ventricle. If we open the left-sided ventricle, it is clearly of a right ventricle morphology. You can see the coarse trabeculations, the tricuspid valve attachment to the septum, and this distinctive muscle bundle that separate the aorta from the ventricle, the crista supraventricularis. So here we can see the aorta coming out from the left. It is left and anterior, and the pulmonary artery is right and posterior. So we can make between the position of the right ventricle and the aorta. So if the right ventricle is on the right, the aorta can be on the right, either anterior or posterior. And if the right ventricle is on the left, as in this specimen here, the aorta can be anterior or posterior. So in this specimen, we have right atrium connected to a left ventricle, and the left ventricle is connected to a pulmonary artery. So we have AV discordance, and from the right ventricle to the pulmonary artery, a VA discordance, and the left atrium connecting to a right ventricle and to aorta. So we have what we call corrected transposition of the great arteries, because the blood still physiologically circulate in the normal pattern. It is important to distinguish these patterns and study them on specimens, as we are doing here, and not only look at the books and look at the pictures in the books. Looking at real specimens is crucial in understanding these complex anatomies. So thank you for your attention, and we'll continue with the next videos.